I'm absolutely delighted to be here. It's been a wonderful conference so far, and I'm having a great time getting to know people. I've been asked to talk to you today about the role of primary care. So, who am I and what am I doing up here? I'm a GP. I'm a freelance locum GP in my own area in Hampshire. But I'm also a patient too. And I'm also a mum to this pair of rascals, who both are also affected by the conditions that we're spending our time thinking about this weekend. About a year ago, I rang Kay, and we started to have some conversations about how we could change the situation as we find it at the moment in terms of the care that we're all receiving from the health service. And as a result of those conversations, Kay and I came up with a few plans as to how we might go about making some changes that hopefully will benefit all of us. We made up a title for me, so I'm the Primary Care Advisor to EDS UK. And then I brought a suggestion, which was that the Royal College of GPs has things called spotlight projects, which is a clinical area that somebody feels hasn't been focused on enough and needs a bit more attention and a bit of highlighting to GPs. And I thought that our conditions absolutely fit the bill for this kind of project. So together we applied for and were successful in getting EDS to be a spotlight project for the Royal College of GPs for this year. So it runs from April 2017 to March, end of March 2018. I then had to apply to be the clinical champion to head up the spotlight project, and thankfully, as nobody else applied, I was successful. When I'm not doing all of that lot, you'll normally find me in my garden, which is my therapy of every sort. I garden on a 2-in-1 gradient, so it's really good for my core muscle strength to balance on that bank and not fall off. And you'll also find me on Twitter quite a lot. And that's my hashtag on Twitter, anyone who wants to follow me. Oh, this picture here, this is me, on a bad day after pain insomnia when I'm supposed to be going to an important meeting and I'm feeling like that. And this is a picture of the Spotlight team with wonderful Lisa and Kay, and unfortunately it's cropped off, but Leslie Cavey is also very much involved. So what am I going to talk about for the next half an hour or so? I'm going to talk a bit about what primary care is. I'm going to try and lift the curtain on the GP consultation. And hopefully, through thinking about that, I hope to help for people to think about how to get the best out of their GP. I'm going to talk briefly about GP referrals on to specialist care. And then I'll just come back to talk a little tiny bit more about the Spotlight project at the end. I'm going to try and remember to audio describe all the cartoons. This is a zebra with his stripes unwinding, and he's saying, "I think it's stress." Who here has got a fantastic GP? Okay. Whose experience is more like this, banging their head against a brick wall, the moments when my thoughts go like, "Bleh," and I just want to cry, steam coming out of your ears, or "It's been lovely, but I have to scream now." So what is primary care? We're meant to be the first point of contact for healthcare. So the patient sitting at the centre, able to directly access their optician, their pharmacist, their community midwife. It's meant to be easily accessible, so people should be able to just get it there and then. When they need it, they can ring up and say, I need to get some help from you directly. And we then have a role as what gets called gatekeepers, although I think the analogy to keeping the gate is a little bit narrow, in that we're not just opening a gate in one direction. We have the key to many gates, and part of our job is to think about which gates it might be helpful to help that patient through. The focus of what we do is to care for people, not diseases. So coming back to the previous talk about, people focusing on organ systems and the bit of the body that they're specialists in, we're specialists in people. We are what's called generalists, dealing with any physical or psychological or social problem that is affecting somebody's health. We treat common illnesses, but we also, a lot of what we do these days is managing or helping patients with their management of long-term conditions, and then also trying to prevent future ill health, and that's very key to general practice as well. Within primary care, we should be very focused on being the patient's advocate, and in working with our patients to coordinate the care of multiple health problems. I mean, we had references yesterday to people getting conflicting pieces of advice about their diet, for example, from their cardiologist and their rheumatologist and their dietitian and somebody else. Our role should be to explore those differences of opinion amongst all of the experts and work with the patient to work out, well, for this individual patient, let's take into account all of the expert advice, but actually trying to make that make sense for this person. What is the right thing for this person to do, given the advice of the experts? We, as GPs particularly, like to build up relationships with people over extended periods of time, years, decades, and often through different generations. And we like to think of ourselves anyway as experts in people. That's what's at the core of general practice, is that we live and we work alongside people, we get to know people as people, and we see the person first, and the diseases are very much secondary in our minds. So, what are we trying to do in general practice? We're trying to do diagnosis, but I've put it in inverted commas. This couple of quotes from the King's Fund report on diagnosis and referral from general practice. The role of the GP in diagnosis is one of problem recognition and decision making. The objective is not always to reach a definitive conclusion in primary care. Diagnosis is a complex area of clinical activity that does not often follow a simple linear sequence. The diagnostic process in general practice is as often a combination of shortcuts, loops, and dead ends as it is a straight line going from presentation to diagnosis. So we're supposed to come up with some kind of a formulation to hang things around, discuss options with our patients, make a safety net, so we've plans for what if this happens, what if that happens, promote people's health and lifestyle. We're trying to keep you well and not get sued. We're in trouble with the GMC or anybody else who has an idea about what we should be doing. We're trying to provide whole person care within people's family and community contexts. And that the community and the family are very, very much important to the approach that general practice brings. And within each consultation, what we're taught to try and do is to elicit the ideas and concerns that the patient is bringing, and also what that patient is, they bring as their expectations, or what do they want us to do about it. So GPs talk about ICE, ideas, concerns and expectations, quite a lot. We're also trying to manage 90% of patient contacts with the NHS, with only 8% of the NHS budget, in 10-minute aliquots of time, for £146 on average per patient per year. So we know that there are increasing stresses on all parts of the health service, but for many GPs, the stresses are starting to show at the moment, but that's not an excuse. So the cartoon here is two doctors talking to one another. The patients know more about their diseases than me. I must get faster modem, higher speed internet access than them. Why are we tricky for our doctors, for our GPs? The simple thing, which is true, is that there is a genuine lack of knowledge and awareness of clinical problems amongst GPs. And as you can guess, that's something that I'd like to do something about, and we're trying to achieve that. But even if your GP has the best sort of knowledge, if I think about myself, obviously I've learnt an awful lot about these conditions over the years, but there are still limitations in the care that I can provide. There are limits in terms of the resources that I have. You know, I'm still supposed to see you in a 10-minute slot. There's a lack of services available to support people in an ongoing way. I can see a patient and realise that they need a really good multidisciplinary team to help them and move them forward for the long term. There's no such service. A lack of specialist support. I do not have a single rheumatologist in the entirety of Hampshire or Wiltshire who will diagnose patients with ehlers-danlos syndrome, hypermobility spectrum disorder, or any of the things that we're talking about. I don't have an immunologist for MCAS. I don't have anybody that I trust in secondary care to refer one of you guys to. We work within an NHS system, a healthcare system that's geared to the single problem. And when, we come with this, the system doesn't know what to do with us. Traditional medical care is taught like this to us as medical students. The patient comes with a presenting complaint, one symptom. We take the history of the presenting complaint, we examine the patient, we do our tests. We then will reach a diagnosis, and treatment will follow on from there. The reality, coming back to what I was just speaking about in terms of doctors needing a test, is that we have to do a degree of living with uncertainty. So this one is a doctor talking to death. I have a theory, but let's wait for the x-rays. We're also taught about common things being common. When you hear hoofbeats, we are meant to think about horses, which of course we all know that we're zebras. And here the doctor talking to the zebra says, you're a perfectly healthy horse, except for the stripes, but I wouldn't worry about the stripes too much. We see this sometimes. You just need to diet and exercise, and if that doesn't work, try these antidepressants. We are taught that uncommon presentations of common things are more likely than uncommon things. So, some simple stuff about using your GP. First of all, don't use your GP. Use your pharmacist instead. I hope Lisa will support me in this. Your local pharmacist will have actually a wealth of resources and knowledge, and sometimes more time and interest. GPs have about 50 patients going through their brains every single day. We get decision fatigue, we get empathy fatigue, and actually if you've got an interested local pharmacist, they may well be of more use to you. I don't know if anyone's used WebGP at all, or an electronic way of interacting with their GP. This will be coming and rolling out, so pretty much everywhere will have this within the year. I think that there actually are some quite useful things about interacting in this way. By answering the questions that the e-consultation process takes you through before you actually have any face-to-face time with your GP, it helps you and the GP to be clear about what it is that you're trying to gain from your consultation. These are silly things, if it's your knee, wear something sensible so you can get to your knee. If you come about your urinary symptoms, please bring your urine sample. Symptom diaries are very helpful for GPs to be able to look at what it is and how often and those kinds of things, and they can be helpful. lists. So, sometimes as a GP, I see somebody coming in with a long list. And it can make me think a few different things. It can make me think this patient's really engaged. They've thought about what it is that they're coming to see me about, and that's really positive. It can also make me think, oh my God, I've got 10 minutes. How am I supposed to start here to address these problems? And a similar set of thoughts with an internet printout. It's not realistic if you bring 50 pages for me to read it there and then in the 10-minute consultation. So I think it's about I think they're useful things to bring, but I think it's about how you think about them and how your GP is going to think about them with you. Be realistic about what your GP can do in that first 10-minute consultation. But it can be helpful to bring that list for the GP to get an overview of, these are all the symptoms that are going on. But be prepared that they're probably not going to get to the bottom of it in your one consultation. You're probably going to need to agree to tackle certain things and then keep coming back. It may seem obvious, but that is how we work as GPs. We expect people to come back. When you're thinking about your what you're going to talk to your GP about beforehand, it can help. I find this helpful when I'm going to see a doctor, is that I've thought in my mind, what ideas, concerns and expectations do I have towards this consultation? So if you think that you've got migraines, it can be helpful to say that up front, that that's what you think is going on, because that will help the GP in their thought process. They might think it's something completely different. But if you've said that you think it's migraines, then your GP will then be able to address why you think it's that, and you might be right or not, but it's explicit and it helps the communication. If you're worried that it's something, if you don't think it is, but it just might be a CSF leak, say that, because again, it allows your GP to explore that with you and try and work out what needs to be done with that level of concern. And your expectations. If you want a referral, you can absolutely suggest that, and if that's what you've gone for to see your GP, do say that out loud, but be prepared for it to be a communication and an exploration of what role that will play in your future care and how that's going to improve your health. So the doctor's saying to the patient, I'll give it to you straight, this disease is almost impossible to pronounce. Thinking about referral. How often do you reckon GPs refer? What percentage of patients do you think we refer? Anyone want to hazard a guess? 20? 10? 5%. So only 1 in 20 consultations will end up with any kind of a referral on for further care. Why do we refer? What's the point of referring for a GP? A few different reasons. It might be for advice on a diagnosis. A patient comes to me with headaches and they don't fit any of the patterns that I know about, and I want somebody else who knows more about headaches to work out what is going on for this patient. It can be for specific treatment or an operation that I believe that patient would benefit from, but that I can't obviously do. I'm not going to do a quick bit of open heart surgery in the middle of my afternoon, so they need an operation that I can't provide for them in the practice. It can be for a test or an investigation that a GP is unable to access directly, so most GPs can't access a CT scan or an MRI. That is changing in some areas of the country, but for many we can't. So if you need an MRI of your brain to work out what's going on with your headaches, then we'll need to refer you to secondary care. It can be for advice on management. I know, I've tried a few things for these migraines, but I'm struggling to help this patient sufficiently, so I'm going to ask somebody. I've tried all the things I feel comfortable with as a GP. I need somebody else to help. And it can be for reassurance. It can be for reassurance of the doctor. I'm just a little tiny bit worried that there's something really serious going on with this patient, and I think it's migraines, but I want the neurologist to just reassure me that that's all it is that I'm dealing with, and then I will carry on and manage this patient myself. Or for reassurance of the patient sometimes, You've had the conversation over and over again about their concern about their headaches being related to a brain tumour, and you just think, there is no way I can't move forward with this patient without putting that worry to rest. There are downsides to referring people. So what happens if I decide to refer someone? Well, nothing for quite a long time, as I'm sure you're all aware. Often huge waits until you actually get seen. So there are upsides and downsides. I often get asked, what do you do if your GP won't refer you? This is a common problem. The cartoon here is the doctor saying to the patient, a second opinion? All right, but I'll charge double for that. My advice, if your GP will not refer you or says that they don't want to refer you for a particular issue that you've asked to be referred, listen to your GP's reason and ask what they plan to do instead. Your GP will always have a plan, but sometimes it helps to know what that exact plan is. Go home and think about it. Think about the proposal that your GP has put on the table as an alternative. If you think your GP might be wrong, and I believe that they will be, not infrequently, what do you do next? And I would say, go back again and try explaining again what you're hoping to achieve from that referral. Often, your previous consultation, the GP will have been trying to do lots of things in that one consultation, and the discussion about a referral may have come towards the end of it. If you go and have another appointment where the entire focus is discussing what would be gained from a referral, it can put a different light on things for the GP. The other trick is to go back and discuss the same symptom several times. We're taught as GPs that if we're trying to help a patient with a symptom that we haven't yet got a diagnosis for and we're not quite sure what's going on with, first of all, we can what we call use time as a diagnostic tool. Many things will just get better if we ignore them. The joke about take some aspirin and come back in a fortnight if you're not better has some merit, actually. But if your symptom has not got better and you continue to return, the level of anxiety in your GP, the third time you go with that same symptom that just doesn't fit in with any of the diagnoses that are in your GP's brain, your GP's anxiety will start to rise to the point where they may well decide that a referral is in fact what is required. And the other tactic would be to try whatever management it is that your GP is suggesting. But then if it isn't helping, go back again. We're taught that patients will just keep coming back. If it didn't work, they'll come back. That's what we're taught. But I know that actually in real life, what often happens is you've seen the GP, what they suggested was useless, and you don't bother to go again. That's what we actually do, isn't it? But if you keep going back and you say, right, I tried that, the GP will start to run out of options. And on the options that they've got, referral is one of the options. Should you see a different GP? This is a difficult one for me. I fundamentally believe in, and I think the evidence strongly supports, continuity of care from one provider to one patient as being the absolute pinnacle of the best healthcare that we can deliver. I know that the systems that we have in place in the current health service do not always enable us to access that decent continuity of care that most of us, I think, would like to have. If you've started to build up that relationship with that GP and you've gone back the second time with the same symptom that hasn't yet come to a conclusion, as it were, or a diagnosis, if you then switch to see a totally different GP, sometimes that GP will just sort of start again, and you won't, if that third consultation with the same symptom is with a different GP, that it doesn't raise the same worries and anxieties in that GP that it would have done if it was the same GP that you'd seen times 1 and 2. Having said that, I have changed GPs myself, having been treated absolutely appallingly and dismissed and told that I was mad. So I think there are times when actually the relationship has reached a point that you need to move on in order not to continue to be traumatised by the healthcare that is currently on offer. So, what am I trying to do to change the way that things are now to make this stuff better for everyone? So, EDS UK, I should have said conflict of interest, is that I am being funded, a few sessions of my time are being funded by EDS UK to run the Spotlight project with the Royal College of GPs. So things about the Spotlight project and about EDS are appearing in the email inboxes of GPs up and down the country as we roll things out to do with the Spotlight project. So that's very much just about raising awareness, just the words ehlers-danlos syndrome, hypermobility, just dripping into GPs' brains. We're working to create an online toolkit. Most of the Spotlight projects that the college has had have, there's a page for clinical toolkits on the Royal College of GPs website, and apparently it's one of the most highly trafficked areas of the RCGP website is these clinical toolkits, so we know they get used by GPs. So we're working to develop a toolkit that will sit on that website and hopefully will help you guys and will help your GPs to help you better. We're also trying to help the experts that we have, and that can be GP experts, but physio experts and pharmacy experts and researchers, as well as the ologists in the hospitals that know about our conditions. We're trying to get the networking better so that we know about each other and we know what each other is doing, and hopefully that will lead to better research collaborations going forward, and to help us. This stuff is difficult. Vic was talking about how there's a paradigm shift, I guess, that needs to happen for doctors in thinking about mast cells and the stuff that's going on there. This is massive, and it's difficult for doctors. We're naturally small c conservative by nature, so it's a big shift. So we need to hold each other's hands a little bit as we take those steps forward. And we hope to develop better services and care pathways for patients. So the toolkit, very, very briefly, last 2 slides. What's in the toolkit? Hopefully, how to spot a zebra, quick guide for doctors. I'm hoping to work with Hannah, Kaz to try and look at when should we be referring, what are we referring for to do with our conditions. A section about management approaches. This will all be this is open access on the web, so everyone will be able to access this. It's not behind a paywall or a login or anything like that. There'll be a section about resources that are specifically aimed towards support for patients, and obviously we'll be highlighting the amazing work of HMSA and EDS UK in supporting patients, carers, families with all of this stuff. There'll be signposting to educational resources for doctors, some researchy, papery stuff, and hopefully also a section about information for the commissioners, so the commissioners who are in charge of deciding what services are available for you guys, for me, and we're trying to work to influence the thought processes of the commissioners as well, so that we can get things to be different. And if you think there's anything that's missing or that I might not have thought of that you would really value, please let me know, because it isn't finished yet. So thank you very much for your time. That's my Twitter handle.